When that bruise continues, it doesn't go away, it becomes tender and sore, weeks go by, now it's chronic pain. And you may go in, somebody may look at your knee and do an MRI and find something torn inside. It may be repairable, and maybe that's fine if you have something repairable, but normally, eventually, you wind up in the pain management man's office when things don't go well, if there's no way to correct it. And that was my office since 1982, until I developed an alternative approach, which we will talk about. So we're going to talk about the conventional mainstream approach, and then we're going to talk about my alternative approach. And later on, I'll give you some insight into my protocol of how it goes for patients next. Well, looking backwards to the earliest 20th century, there was no alternative medicine. Everything was out there. There was naturopaths, homeopaths, traditional. There was colonic therapy. Well, what happened in 1910 was the Flexner Report, which deemed all this stuff to be unscientific and not worthy of insurance coverage, not worthy of medical school training, and so on. It was all thrown out. The only thing that was left was allopathic medicine, which now we call conventional medicine. Next, please. And back in the early part of the 20th century, they were working in areas. There was early recognition of people that there were dental issues involved and bowel sources of infections that were probably causing arthritis. There were people concerned about this, and they were beginning to use antibiotics to treat arthritis. Unfortunately, for a lot of us, and for the patient population, all this was abandoned with the discovery of cortisone. And that's an important thing, and we're going to have to talk about cortisone because it really shaped the way the whole specialty of pain management has gone. Next slide, please. They also were working with destroying tissue in order to interrupt pain. And they were freezing nerves and putting chemicals on nerves, chemical poisons, alcohols and phenols, and burning nerves. So this was all being attempted as well. It's still being attempted. Next, please. Well, let's roll up to World War II. And that's the beginning of pain management in America. What happened was in Seattle and in other places, wounded soldiers were coming back and they were getting local anesthetic blocks and injections, and it seemed to be helping them. So that was the beginning of pain clinics in America. John Bonica was given the credit for this, a famous anesthesiologist. And around the same time, the drug cortisone was discovered. And I want to stop and give you an idea of what cortisone is. Cortisone is a naturally occurring hormone from the adrenal glands. It's a stress hormone, meaning that it comes out when you're in a state of stress. And in that state of stress, your body ignores healing anything and takes care of the stress. So that's why cortisone comes out. The main things, it's really good at knocking down inflammation. Redness comes out of things and things quiet down. Unfortunately, the other side of the coin is it also blocks your immunity. So it inhibits your body from fighting. That's what it does. And it was hailed as a wonder drug for arthritis when it first came out. At one point, they thought that arthritis was a deficiency of cortisone. That's what it was called. They gave cortisone to some arthritics who couldn't move, and they just, within hours, they started getting up and moving around. It was considered, it just threw everything onto the back burner. Well, John F. Kennedy was also a World War II wounded soldier. He came back from the war with a bad back. It's all famous. He got involved in his PT boat, got hurt, and he was treated by another famous doctor, Janet Traval. He was given cortisone injections and local anesthetics, and it got him up and around. Of course, he didn't live long enough for us to see what might have become of those injuries. But because the president got those treatments, they became the gold standard for today, and they still are. Local anesthetics and cortisone, steroid injections. It cuts across all specialties. You will find podiatrists giving those shots. You will find eye doctors putting those shots in. You will find orthopedic surgeons, general surgeons. Anytime something hurts, local anesthetic and cortisone, boom. If you go to your internist, you will get cortisone in your behind. So this is the gold standard today based on John Kennedy's treatment. Now what happened was, Kennedy developed a side effect. He became Addisonian, and we really don't know what would have happened to him had he waited. I think I know, but he was unfortunately killed. Next slide, please. Well, this is the conventional mantra. This is the conventional mantra, and this is how it goes. An injury occurs. It gets inflamed. A cortisone injection takes place. It blocks the inflammation. Whether it blocks it or not, probably it does. But if the cortisone wasn't here, it would go to swelling, which would reduce blood flow to the area. And that's sometimes we hear that you put ice on this. Eventually, what will happen is the tissues will not have enough oxygen or blood. They'll get ischemic. They'll have trouble breathing. Maybe they'll get damaged. That nerve damage goes on to chronic pain. So this is the general conventional mantra, and we'll come back to this later on in the discussion. But the cortisone was considered to be a wonderful chemical ice pack. You give it, shoot it up, and the swelling goes away, blood flow increases. Boy, didn't you do a great thing? Maybe there's no nerve damage, no chronic pain. So that was the thought process. Next slide, please. And this is the way it went. Local anesthetic and steroids for any form of pain. And if you go into a pain management doctor today, you will get a local anesthetic and a steroid pretty much. I mean, maybe you'll get chiropractic therapy if you're in your chiropractor. Maybe you'll get some other lower, lesser degree treatment. You might get acupuncture. But if you're really bad and you go into my specialty that I'm in since 1982, you're going to get a steroid and a local injected into you in some form or given orally. Now that treatment will fail in many cases. And the next step that will go will be destruction of the nerves with surgery, chemicals, or microwaves or freezing. And the microwave burning is also known as radio frequency lesion. If you've heard that term, that's what it is, microwave burning. Finally, when all else fails, you'll be given narcotics or other analgesics. And now, increasingly, we're going to narcotics because they're slightly less toxic than the other options. So the final solution, and the double meaning is intentional, is to be warehoused on narcotics for the rest of your life. And you'll probably wind up in Florida, because that's where the narcotics are available. They're available down there, and it's become a huge problem in the United States. Next slide, please. So conventional pain management treatments fail commonly. And this is no secret. You're here because you know that. You know that and we all know somebody who's had chronic pain and is not responding to conventional approach. Well, the studies now support that the conventional approach is working. They've done studies on steroids, and the steroids do not provide any more than short-term benefit on occasion. And they've done studies on local anesthetic injections. Again, very low percentage of success. Now, destruction of nerves, again, only gives temporary relief at best. There is not permanent improvement from any of these things. Well, what's happening now is you're getting an increasing number of patients failing and moving on to long-term narcotic management. It is a huge problem in the United States. Insurance companies are aware of this. They've come out with new guidelines since 2010, severely limiting these treatments. They know that it's not working. They've got guidelines that say if you don't get this number of months from the last injection, no more, we won't pay for any more. They understand. They're tightening down because they know it doesn't work. Next slide. Well, the question is why? Why can't we control inflammation? Why don't the steroids help? Why does the inflammation always return? Why does nerve destruction only give us temporary relief? You would think if you destroyed the nerve, you're going to be fine. Not true. Well, why does the pain travel? Why do you wind up with some problem here? Next thing you know, you've got a TMJ. Next thing you know, it hurts your shoulder. The pain travels and gets worse. Why do chronic patients need more and stronger pain medicines? Why? We know this. We've seen these patients. We know these are family members. They need more and more. They chase the drugs. Why don't chronic pain patients just get better? Why don't they just heal instead of getting worse? I mean, why? We've all been sick. We get better. We don't just continuously die from the first thing that we get. But pain patients don't. They get worse. Thank you. Next slide. Well, there are more questions. Why are these mainstream treatments useless for so many patients? Could these treatments be preventing healing? Is that possible? Could the steroids be making things worse? Could the need for stronger pain drugs be addiction? Or, as I would think, could it be because the pain is getting worse? That's why they need more drugs? Next slide. Well, there's something missing from this picture. I knew it. Every pain management person that you know knows this. He may not tell you this, but everyone knows this, that we are not helping the patients. They are funneling down into a mess. And in my office, by the time I was in practice 10 years, I had the Hall of Pain. That's what we used to call a pain. A bunch of patients who were being managed and were calling up for medications and chasing me, and then there were contracts that I had to have them sign and call up pharmacies. It was a mess. And this is the state of affairs everywhere. I know, I talk to these people. I said, what do you do with your patients when they fail? Well, we send them here, or we send them there. That's what, but if you ask a pain management doctor, he's going to tell you that he sends them somewhere. This is the end of the road. Next slide, please. Well, as a physician, I went into anesthesia because it was upsetting for me to hear patients complain about their sorrows. Unfortunately, I listen to patients. Well, a doctor should do that. So in 1993, one of my patients from New Jersey went to an alternative doctor in New York City, and she got treated with intravenous hydrogen peroxide. She came back, she had a gift for me. I couldn't believe it. She had pain relief. And I really didn't understand why. But because the patient said something I didn't understand didn't mean I shouldn't investigate and figure it out. So I went, I learned about this. I didn't know why it worked. And it didn't make sense. Because this peroxide infusion, and by the way, we're not talking about regular peroxide. We're talking about drops of peroxide in water, very little. So it wasn't like she was getting oxygen or anything from the peroxide. And they, in the old days, before they had antibiotics, they used to try to give anything to a patient to kill infection. They would try anything. And somebody tried giving a little bit of peroxide in an IV, and they used it to treat influenza. They had an influenza outbreak in India, and that's where they tried it for first. But why would an infection treatment make bladder pain go away? Well, she was feeling better. She started talking around the practice. Pretty soon, a whole bunch of chronic pain patients wanted this treatment. Dr. Webb, you have to give me this. So I gave them the treatment. Well, this is what happened next. Everybody got reactions and everybody got better. And I scrambled to collect the data because I could not believe it. Well, this is part of a slide that I presented at a doctor's meeting in 1999. And it summarizes pretty much what I saw. 57 patients received 500 infusions of this dilute peroxide. And these two numbers you could ignore, but there was another number here that's important. 2/3 said they had more than significant improvement, and almost everybody wanted another infusion. So you can say, well, they wanted another infusion because they wanted your pain medicine. And of course they said that they were feeling better, but the fact of the matter was, almost 90% of these people reduce their pain medicine. Pain patients don't reduce pain medicine. That doesn't happen. You don't see that. I mean, even they have to be much better to do that because they'll hoard it, they'll keep it just in case they're having a bad day. When I saw that, that was so significant. Next slide, please. But the real kicker was yet to come. Because as these patients felt better, they showed all the classical medical school signs of a resolving infection. This is stuff no doctor could deny. You couldn't have a failed back surgery open up, the wound would crust up, and open up, and out would come pus, and I would culture the pus, and it would be positive. How could that be? You mean to say that had an infection all along? And then the patients who didn't have wounds, they had fever and chills, they had drainage from their sinuses, they were coughing up junk, the urine would smell, we'd culture it, it would culture positive, and then it would clear through, and these people all were getting better. This was remarkable, and it caused me to totally rethink the paradigm that I was trained to do. Next slide. Well, I began going to alternative meetings, and I met other alternative doctors who were doing other alternative therapies, all of which were anti-infective. We had doctors using minocycline to treat things, doctors using doxycycline, doctors using ozone therapy, ultraviolet blood therapy. There were people giving their patients certain strong, potent herbs. There was Oriental doctors who were using Oriental herbs. They all had the same stories as I am. And I realized that if it's an anti-infective therapy, it's going to cause patients to detoxify and feel better. There was no way to deny this. Next slide. And I therefore proposed a mechanism which I no longer propose, I now stand by, that infection causes a chronic inflammation and thereby sustains a chronic painful condition. Well, here at the Patient's Medical, I think everybody kind of understands this. They may not have the same grasp of it that I do, but everybody understands that mainstream conventional treatments are not effective for many patients. And chronic pain is caused by an injury or a lesion that can't heal. We talk a lot about healing here, but that's really important. And you can't heal if you have infection in the tissue. It just won't happen. I mean, if you've got a cut on your arm and you don't clean it out, you've got dirt in there and it gets red and infected, I mean, it's not going to heal. We all know that. And it's no difference inside your body. Next slide, please. And this is what you saw earlier. The injury, the inflammation that gets blocked by cortisone, the swelling, but here again, the infection gets involved. And this is not recognized by mainstream medicine. It's just a blind spot right now. Not to me, but to everybody else. And the infection starts a vicious cycle. The cortisone allows the infection to get established. The infection then destroys the tissues and causes chronic inflammation and on until you wind up with chronic pain. And this is what's going on. Next slide, please. Now this man, I took pictures when things started happening in practice. I should have taken more. But this is a young man who went to work after he got out of the Marine Corps. He got a job with a truck, and he got impaled with the forklift or some such thing, or the lift. He got impaled right over here in his femur. And he developed what they call reflex sympathetic dystrophy and severe chronic pain. He was eating pain medicines, and he was my patient for a while. And this wound was about 5 years old at the time when this picture was taken. And it was completely this color until he started getting anti-infective therapy. What happened was it started getting red. The area started getting red, it started bubbling up. Next thing you know, it opened up afterwards. You don't see that in this picture, but this was when it started to feed. He said, Dr. Wade, what's going on here? Eventually, I cultured it when it opened, and it was pus coming out. This man, for 5 years, had inflammatory infection going on in his femur. And he was not the only one. The whole practice was dealing with stuff like this. Next slide, please. So, in summary, Chronic pain is generated by damaged tissue that is not recovering or healing. Common sense. Restoring the tissues to health will make them heal and stop hurting. More common sense. Healthy tissue cannot exist in the presence of infection. Anyone who thinks that they can is deluding themselves. If you're infected, you will not heal. You may stop bleeding, but you're not healing. Anything that reduces infection will reduce inflammation, allow healing, treat, and eventually eliminate pain. That is, unless you have a structural problem. If you have a structural problem, no amount of reduced infection, you need to correct the structural problem. For instance, if you have a broken bone, you set the broken bone, keep it nice and clean inside, the bone will heal, and then you're fine. So we're not talking about structural deficiencies, but the opposite is also true. If you're doing anything that favors infection, you'll increase the pain. And when you looked at my practice in New Jersey, and we looked at the failures across the board, the people who just were not getting better, 100% of them were smokers. It got so bad that I refused to accept smokers in my practice. I said, you're not, and there's a reason why. Smoking really increases pain. And it was really upsetting to me because I had patients coming in who were smokers, and I knew that the smoking was causing their immune system to be knocked down. And they would go to a specialist, well, I remember very clearly, a world-famous headache specialist who said, smoking has nothing to do with your headache. And it just blew my mind. But what can I say? Doctors didn't get where I am now. They will somehow. Excellent. So, are germs keeping me in pain? Is my chronic pain that simple? Are you? That's a good idea. Open the book.
It may be very hard to hear once you open those.
Oh.
It's probably a better idea to open the door. Yeah.
All right. Well, they were making a lot of racket out there. That was
It's
why.
probably done now.
Okay. Yeah, you're right. Okay. Maybe you should. Well, if you can't hear, you should. So, is it that simple? Is my chronic pain that simple? And what kind of germs would do this? Where did they come from? Why did my body get rid of them? Isn't the inside of my body sterile? How did these germs get into my painful areas? Am I doing something that caused this infection? You better close it, please. Thanks. So, and why didn't the antibiotics clear it up? Good. And what about exceptions? Well, there are exceptions. You know, you can have diabetic neuropathy. You can have cancer pain from cancer. So there are some exceptions. And you can have ischemia, you can have chest pain from a heart problem. But the exceptions are really rare. They're not really common. If you're in a pain management guy's office, this has all been ruled out. Next slide, please. So the answer is simple, but it's not an easy answer. And some of the answers are, well, there are common germs that exist in uncommon forms. Well, what do I mean by that? You know, I use the example of the cabbage. The cabbage is a nice green vegetable about the size of our head, you know, and we know exactly what it looks like. But you know what a cabbage seed looks like? It's a dot. It's a dot. So it turns out that common germs that we've all heard of, I can rattle off the names, E. coli and so on, they have spore forms. These spores have scientific names. They call them L forms after Lister, from an early scientist. They call them pleomorphic forms. So they are small forms of common germs. And they exist inside cells, and they slowly cause havoc. And your body is not sterile. Your body has reservoirs of germs. Well, where would there be reservoirs? In the teeth. That's a major area. We have Dr. Sivilek here, who is my consultant for these problems. And if you have chronic pain, and you have chronic, you need to have your teeth looked at. If you've got any dead tissue in your mouth, it's probably festering, just like a foreign body or a wood splinter in your finger. It's going to get infected. A dead tooth, be it a root canal or a dead molar, or maybe somebody took out a molar and there's some infection where they left in the site. It has to be looked at and it will continuously feed the body. It will continuously feed the body, and you will get chronic infections spreading through your system. And then it will go to an area which has just been damaged or bruised. And we'll talk about that some more. The bowel's another section that has a lot of problems. The bowel can leak. Certain conditions, poor diet, fungus in the bowel, can cause the bowel to, like the sidewalk outside, to have the trees come up through it and leakage. And then leakage will cause infection to come out of the bowel, into lymphatics, into your bloodstream, and populate wherever it wants to go. There are vaginal problems with yeast. There are prostate problems in men. All these are reservoirs of germs. And how do these germs go through your body? Real easy. They go in the blood, they go in the lymphatics, and they probably go along the acupuncture meridians. So why do these germs stay in inflamed areas? The reason for that is because they don't like oxygen. Well, if germs liked oxygen, they wouldn't invade your body. They would stay on the outside where there's plenty of oxygen. They wouldn't go into you. The reason they go into you is because they don't like oxygen. And once they're in you, they want to go to an area that has the least amount of oxygen. Well, where do you think that area would be? In a bruise, in an inflammation, in a black and blue mark. That's the best place for a germ to go. And once it goes there, it wants to stay there. So it starts to protect itself. It might form a nodule. It might calcify. That's why it wants to stay there. Now, could your immune system take care of it? Is your immune system suppressed or overwhelmed? And the answer is yes and yes. When you get major amounts of infection in your body, either from your teeth or from wherever, your immune system is overwhelmed. If you're a smoker, you're using steroids, I'm going to give it. Your immune system will be. So this is some of the common type of comebacks that I've gotten. And, just get a little sip of water and go on. Thank you. Doctor, I was given an epidural for back pain. Will that make me worse? My brother had one. He's doing fine. I don't know when the steroid in your epidural is going to cause the problem. You know, I gave hundreds and hundreds of these injections. Most of the people I never saw again. Do I know if they came back to another doctor? But the ones that did come back, they all had problems. I gave an epidural injection to a guy. He became diabetic for 2 years. Don't think the steroids in the epidural just go in and out. They stay in your body for months and perhaps years. They call them depot steroids. The reason they're called depot is because they are a deposit of steroid that slowly come out. You get three epidurals, your immune system is affected for at least a year, at least. Now, some people will be fine. Some people are quite healthy. You know, there's a difference between an athlete getting a steroid shot who has a super powerful immune system because he was injured in this weekend's football game, and you shut down the immunity to let him heal up faster, and he's got the immunity of 3 horses, versus you and I. We don't have that. We're not professional athletes. So that's the answer to this. I won't do one epidural on any patient, period. And I gave it up a long, long time ago. And is cortisone always a bad idea? Well, I'll give you the two extremes. You're losing your vision. Your eye doctor gives you a steroid shot to prevent your vision from leaving you. He wants to protect the optic nerve. Is that a bad idea? Absolutely not. You don't want to lose your eye. Or your throat is closing. You're in the emergency room. The doctor wants to knock out that allergic reaction, so he gives you cortisone or another steroid. Bad idea. You have to take it. It's for life saving. That's one extreme. And here's the other extreme. You know, you've got these blemishes. Your doctor said, take some steroid cream and rub it on and you'll do fine. absolutely unnecessary. You'll be fine anyway. Point is that most steroid use is probably a bad idea, only for life-threatening or organ-threatening situations. Well, people say, how could the chronic pain from a herniated disc be from infection? And the answer is, it is, and I'll tell you why. Not only is the inflammation caused by infection, but the herniation itself is caused by infection. And here's what happened. Unless you're Joe Montana and you got hit, or you're in a serious car accident and you actually smashed your back, but most of the time, a herniated disc is caused by a relatively mild trauma, a false movement or something. The area was so debilitated and, quote, degenerative, that it just broke down and the stuff came out and it burned the hell out of the tissues, and that's where you're at. What happened was your bowel probably was infected. Your bowel was leaking. Where does the bowel leak? It's right below the area. It leaks into the lymphatics. Up the lymphatics it goes, and it populates the retroperitoneal area right around the lumbar discs. Right around it. And slowly, these little infections begin to emit enzymes to break down the tissue. Slowly, over years. And you get an x-ray, your doctor says, you've got degenerative disease in the spine. What he's saying is that the tissues have broken down. Why did the tissues break down? Well, that's normal aging. It's not normal aging. That's the degeneration from the infections. And once you get something happening, disc material coming out, a pop, now you've got acute inflammation on top of the chronic inflammation. Somebody gives you a steroid shot, you feel better for a while, maybe you heal up, maybe you don't. It's not going away. Now, why would smoking make my pain worse? Dr. Wake doesn't want me to smoke. What's that got to do with anything? Well, smoking is an addictive habit. The reason it's an addictive habit is because smoke contains carbon monoxide. And carbon monoxide replaces oxygen in the brain. When it replaces oxygen in the brain feels like it's drowning. And when the brain thinks it's drowning, it issues its own endorphins. Those endorphins act like a cortisone shot. They shut down immunity and they allow infection to take over because it's the body's way of accepting death. So smokers are on their own form of immune suppression. Then the final question would be, what about the pain medicine? Well, this is a difficult question because you need to take pain medicine. Unfortunately, both types of pain medicine that are used today, both of them do inhibit immunity and do prolong disease. But it's the kind of thing that you do take as little as you need. And here's what they are. The narcotics in narcotic pain medicine are the same as the endorphins that the brain issues. They suppress immunity. If you take enough of them, you'll actually stop your own production of many hormones. And now, what about the non-steroidal, the Motrins? Well, the Motrins work by shrinking cells. So they shrink the cells in your intestines. So you will get the leaky bowel syndrome from non-steroidals. Again, one has to make do with the lesser of evils. Next slide, please. Well, about 20 years ago, when I realized what I was dealing with, I had to develop an anti-infective pain protocol. And so I started doing it, and I realized not every patient's the same. And every few months or so, I find a few little pieces and I fill it in. And so the thing has grown over the years. If you Google my name, you will find stuff like this. And I can't get it off the internet because some of the stuff is old and has been changed. So if you do find an anti-infective protocol of mine on the internet, I suggest you come to me as a patient rather than just following it. Next slide. Well, this is the way I approach the patients. The first thing I try to do is to detoxify them, clear their body of infections as fast and as quickly as I can. And since they're all toxic, I try to use a wide spectrum therapy usually an oxidative therapy. And the oxidative therapies are peroxide ozone, ultraviolet blood irradiation, and hyperbaric oxygen. They're wide spectrum, they don't cause much damage to the body. Ozone can be nasty, but the peroxide and the hyperbaric oxygen and the UV are really mild, and they really do a wonderful job of reducing the overall load of infection in the patient. I'll then go with antibiotics. Some mainstream doctors only work with antibiotics. And also, I will then probably send the patient to one of the other doctors here who are really good at supplements and oral and IV, vitamin C and so on. So that's the first step, is knock down the general load of infection. Next slide, please. And once I've started that, I'll concomitantly start to look for sources. And the dental source is the one that is very, very important. So the patients will often get sent to Dr. Civilak or to some other physician who has the capabilities of looking for the sources of dental pain and get them out. Because the faster we get the problems out, the faster we can get the patient better. Bowel cleaning is important. We've noticed a lot of problems in the sinus area. We've noticed that a lot of people who have sinus infections, they finally realize that those are fungal. They didn't know that. And what I found out is that by treating the fungal infection in the sinuses, you can actually prevent and reverse gastrointestinal reflux, GERD, because it goes down and it sets up the GERD situation. Of course, I run right into the GI doctors who have absolutely no understanding of this and are still treating that disease by stopping the acid flow. And there are other fungal locations I'm always learning about. I always was concerned about toe fungus, and I thought it was a secondary problem to bowel fungus. It turns out it may be the other way around. So I'm now looking at nail cultures and looking at laser treatment. Next slide, please. Well, the third section of the anti-infective protocols, I try to support the body's own immune system. Unfortunately, it's not, except for lifestyle, exercise, and so on, it's very difficult to increase your immunity. But as you reduce the infection load, your immunity does go up. Patients report that their allergies get better as we clean them. We see they can't smoke. Smoking is absolutely forbidden. And if you're going to smoke, don't be my patient. It's just as simple as that. And we try to reduce or eliminate the pain medicines. That helps. But very important, you can't be taking these DMARDs they call, Enbrel, methotrexate. You can't be taking these things. And unfortunately, they're difficult to remove, but we have to do it. Final slide. And the last thing is you've got to educate the patients and you've got to follow them. The patient has to know what to expect. The patient has to understand that there's going to be detoxification reactions. And the protocol has to be navigated directly for each individual patient. It's not just a one-size-fits-all. Some people can't take IVs. Some people can't take UV. Some people can't take antibiotics. Every patient has to be specifically navigated. And you must consult with their physicians, and the physicians, the people that we consult here, fortunately are aware of these things, but if you're talking to the family doctor of the patient, you have to deal with that, and that's not so easy. And the patient may be coping with hostile social environment for healing. I know one lady that I advised to do one thing, and daughter said do what Dr. Wade says. Brother said no, we need her to have an infusion of prednisone because Christmas is coming and we want her to be okay for Christmas. So, we've seen everything. Eventually, I don't want the patient to come to me forever. I want the patient to be able to take care of themselves at home. And I try to tailor things so that people can do it themselves at home and come to me infrequently. And that's the end of our presentation today. Next. So if you have questions, now's the time to ask. Yeah, well,
Sometimes with, let's say, HIV, you have a test called a viral load. They do a blood test where you can see how much virus the person has. Do they have something for an infection?
You know, that's the best question. Diagnosis is very difficult. And for me, I'm not an infectious disease person. So if I have a patient coming in chronic pain, rather than say, well, can I diagnose them as infected, I just go ahead and treat, and they get better. Because either way, I'm going to think that they're infected. So I empirically treat. If a patient is starting to improve, then there's no question about it. And after time and time again, where I got improvement, I finally had to say, you know what, don't bother doing that. If someone is in chronic pain, trust me, either they have cancer, which I probably know, or they'll have diabetes, or they'll have an infection, and it's almost always infection. Yes.
The CRP might shed some light on that, C-reactive protein test.
Yeah, but what is that telling me?
It's just really,
I
that
know.
doesn't
I understand.
raise, but
Yeah.
it doesn't give anything specific.
Well, that's the point. Either they have C-reactive protein or they don't.
Sedimentation, yeah.
So, and if you're coming to me, you're already at the end of your rope. I'm going to start some of these therapies as gentle and as soft as I can. And I might shake the tree and the CRP might go up. I mean, I've seen that. I mean, we used to look at PCR studies for chlamydia pneumonia. We used to look at that. If the person had chlamydia pneumonia, then I would give them a different antibiotic than the others. I would give them a Z-Pack. I'm not sure it really made a difference, but it's still evolving. What patients were infected with 5 years ago, they may not be infected with today. So this is what we're going to think. Next, anybody else? Yes.
I felt a little, to your slides, I was confused in your position about the steroids. On one you said steroids make things worse, and as you and I discussed, I completely understand that. I spent a year being sick after having all those injections, but at the same time, another one you were explaining, in certain life-saving cases you need it.
Have no choice. Yeah.
So, I was repeatedly told I was lucky that they caught my pain syndrome so early, because otherwise I would have been permanently disabled if I hadn't had those injections. And I'm repeatedly being told that by so many. Every time I go to a healthcare professional, I'm told just how lucky I am.
I don't believe that. My father was very ill some years back in a Philadelphia hospital, and they told him if we don't put steroids on his skin's going to break down. They told him that. And I threw the head. This is University of Pennsylvania. That's a famous hospital, university down in Philadelphia. I said, don't put steroids on him, please. Do not put steroids on him. I don't care. Let his skin break down. His skin did not break down. I don't believe that you would be permanently disabled without steroids. That's a bunch of crap. I mean, if your eye, I'm not going to take a chance with your vision, if you understand. If your optic nerve is swollen and an ophthalmologist, I'm not going to take that chance. I'll accept the steroid and then try to come back from it, you see. But not in my specialty, no one's going to tell me that story. Because you describe me as my specialty, pain management, right?
Right. I mean, I had immediate relief after the first
Of
operation.
course you
I
had.
didn't stay from the other ones.
Well,
The first one.
I mean, I just was on, heard from a lady who had a tendon tear. So she had a tendon tear, and they said, we're going to have to give you a steroid shot to knock the inflammation down. So they gave her the steroid shot, knocked it, in her heel, and it healed up, okay. And then 3 months later, the opposite side ruptured. Now, she didn't put it together, but by setting up the situation to, I don't believe that anything happens for no reason. You see, and you got to understand, that's why I showed you in the first slide, that I've been in this field so long, I've seen so much of this stuff, I won't do it. I'm not waiting for the studies. I'm not waiting for the studies to tell people like you, don't get a steroid shot. Don't believe it. These guys that are telling you that, they were in high school when I was seeing patients. Did you have a question? No? Yeah, Gary?
Can you, is there any way do a differential diagnosis between what you would suspect is a bacterial versus a fungal infection in the case of a chronic pain patient. You know,
I understand what you're saying. Generally, first of all,
and of course, that would determine your.
I have to tell you, you know, I mean, I don't try to make a differential diagnosis. I actually work empirically. If people get response to someone, now with fungus on the other hand, I can sometimes make a diagnosis. If I look at your nail beds and they don't look right, and I suspect that you may have fungus, I can order a culture of your nails. And I've started to do that now. But it's not very easy. And there are the C-reactive protein, there's PCR studies for chlamydia and things, but it hasn't assisted me.
What prompts my question is because you believe, I think you expressed in the past that you believe like GERD is fungal.
Well, fungal from the back of the throat, yeah.
Okay. So if a patient presents with that kind of symptom, that would be easy.
Well, yeah, but they won't usually come to me. You know, they won't come to me with GERD, they'll come to somebody else. I incidentally discovered that, by accident, when somebody who was taking antifungals got better. And I said, why would they get better? And then I realized that they're swallowing fungal from the back of the throat. I would normally not treat that. I would send that out. I try to focus just on my specialty, which is pain control and so on. Anybody else? Yeah.
With pain control, sorry, two parts. Hypothyroid conditions and pain, they can sometimes be correlated. And also, do you work with neurotransmitters and pain
I
modification?
don't. I'm aware of what you're talking about. If I see it, you know, especially in this practice, we've got some good people here. I probably will refer that to rule out. Yes, you can have some problems with hypothyroid pain, but it's not my first guess. Yes, sir.
You mentioned RSD before.
Yes.
Or CRPS, which
Yeah,
my wife has. What's been your experience with that?
Well,
My wife's had it for 5 years and
Again,
nothing seems to work.
well, this is a common story, and what I believe that is, that's...
Well, I take that, the only thing that does work, in her experience, is ketamine infusion.
Excuse me?
Ketamine.
Ketamine, sure. How does she take it? How does she take it?
An infusion, soldier. Usually.
I'm very familiar with regular. You know, most of the ketamine work was done based on my work. So I'm very familiar. It's not going to cure her. It's just going to make her feel better. It's going to set her pain drugs back. You know, set her back. She's got a chronic infection. You know, it's just going to get worse and worse until we start unraveling her the way I just said. She has to have her teeth looked at. I found so many people with RSD, the upper extremity, who had like a bad tooth right ipsilaterally. I found a guy who had RSD. He had an infected prostate. We had to get that out. I mean, your wife has a vasculitis. That's what it is. A vascular infection, in addition to the tissues being infected.
But wouldn't any infection would elevate your white blood cell?
Not necessarily. Your immune system could be overwhelmed. You know, it could be already suppressed. You know, the only way is to challenge somebody like your wife with different anti-infectives and see what happens. And unfortunately, when somebody is sick for so many years, there's a healing crisis that they can have that can be very frightening. So that's why, you know, a patient like your wife will go to the internet and read up about hydrogen peroxide baths that I use in my practice. Go into it, and next thing you know, she'll feel worse and say that guy's crazy. It has to be done very carefully. You have to pull the toxins off of her slowly. You know, where's her RSD?
It started in her feet. There was a foot surgery on her foot, but it's basically spread to her extremity, mostly her feet and her hands too.
It's tough, and why would pain spread, you know? And I remember they used to tell us it can never go across the midline. RSD can never cross the midline, they told us. Your wife's crossed the midline, didn't it? That was like written in stone when I went for my specialty training. crap. It goes anywhere. So how come? What explanation do you have for pain that moves around?
So what works best, like peroxide?
No, what works best is slow, you know, I have to see the patient, I have to slowly work with her, you know, maybe start to look and see what the problem is, talk to the patient, and you find out, and you'll talk to people and say, you know, I was doing okay, and, you know, the doctor gave me, and I hear, oh my God, there's an abscess in the mouth. You know, we've seen stuff like this. I don't know. I mean, each patient is different. You know, bring her in, she'll have a consultation, that's what I would suggest. Will she get better? I think she'll get something, probably better. It may be rocky though. A person who's sick, it's rough.
All right, we'll take one more question. I think I need to wrap up after that.
Joel?
So how can people use this proactively to stay healthy?
Oh, that's easy. I can set you up with that. No, seriously, I myself do things, I stay on my own protocol to stay healthy. I detoxify myself on a regular basis. I do the hydrogen peroxide therapy at home on a regular basis to keep myself, because I have joint pain, I want to keep it out. And by keeping my body clean, it does prevent the aches and pains. Have I had joint problems? Absolutely, I have a joint replacement. Because as clean as you keep yourself, if you wore out your joints, you're not going to be able to bring them back. Unless we develop the stem cell technology that's being worked on, and it was attempted on me in another center, it didn't work, I had to have a joint replacement. I probably was not as aggressive as I should have been, but that's it. Anybody else?